All right. Well, welcome to today's IDRPP Early Intervention Echo. If you've not taken a minute, please put your name and contact information into the chat. If you're able to tell us where you're from and turn on your camera, that would be amazing. We are recording today's session. It is always stored on our Canvas page as well as our YouTube channel, so you are able to go back and review the information. Sometimes we are sharing a lot of information all at once, and if you're anything like me, it takes a minute to digest it. So going back and hearing that again really solidifies it for me. Echo is an interactive participation. So like I said, if you're able to turn those cameras on, it's almost like we're in person. But I know sometimes we're eating and that's not always the easiest thing to do. So if you also have any questions or comments that you want to put into chat, we will make sure we get those answered for you or share that information out. We do talk about individual privacy, so please avoid using any first or last names, mother's maiden name, your social security. If you have any questions, reach out to one of our amazing hub members. They all have an asterisk in front of their name, and they would be able to help you de-identify that information. Key components of an echo session is that we will always have a didactic speaker. Then my favorite part of the echoes is our case presentations, where all of you amazing people on the call share your resources and recommendations on how to help this case. So it's a great way to develop that professional networking and knowing who we can reach out to throughout our community. Sometimes as an early intervention Part C provider, we're out in our cars, isolated from our colleagues and different connections. And so this is a great way to just learn who I can reach out to. So Kate Murphy is showing on my screen. I know that I could, if she shared something in my small breakout, I know that I could reach out to her again and ask her to give me some more feedback or suggestions on what she shared. So it's a great way to do that. Renaming your profile, again, is just a way that we can know who's on the call, know who we're talking to. If we were all in person, we'd be chit-chatting amongst each other in the room and getting to know each other. So it's just a way to continue to build that networking in a virtual world. To get a credit of attendance, we ask that you fill out the survey. You guys do not realize how much that survey provides resources and information for us to take back to our funders so that we can keep these free of charge. It's a really powerful tool that we're able to share with everybody. So that's how we send out those credit for attendance. So thank you, everybody who always does those, and hopefully you have gotten some follow-up calls and got some Echo swag. But if not, reach out to us and we'll do a follow-up call and send out some swag. That's our way of saying thank you for doing that. Canvas is where we store everything. So if you ever want access to our Canvas page, please just send us an email at earlyecho@usu.edu. Case studies, like I said, they are the best way to get recommendations about some of the clients and families that we work with. So please consider sending us in a case study. We do have social media that we share resources about upcoming sessions, some of our different networks that we have here at the Institute, as well as information that is provided to us that we want to get out to everybody. So if you've not taken a minute, go ahead and follow us on social media. So I'm going to go ahead and stop sharing and turn the time over to our amazing didactic speaker today, Pat Boyle.
All right. So this was a presentation that we decided to do as our NICU roundup. So Rebecca, who is unfortunately not here, and I collaborated on the presentation. I am a pediatric physical therapist. I've worked in a variety of environments, including levels birth 2, 3, 4 NICUs, early interventions. And so I have that perspective, and Rebecca is obviously in a rural area, and she has her perspective of receiving these kiddos into your community. So this is the end of our NICU series. We thought it would be beneficial to talk about babies and their families who have spent many months in a higher level NICU, and some of our medical and developmental challenges they face recovering both before and after their discharge. So the one thing that when I'm interviewing a family, they say, oh, the baby was born at Primary Children's. I said, no, babies are not born at Primary Children's unless they come through the emergency room and you're a teen pregnancy. So our level 4 NICUs, our cardiac ICU and our pediatric ICUs are specialized units that serve little ones and their families with complex diagnoses. Most of these kiddos require surgeries. So in Utah, which is the area that I'm the most familiar with, I've seen babies born in a level 3. So often when a mom is pregnant, she receives her 20-week ultrasound, many birth defects are diagnosed, and arrangements are then made to transfer the birth to the University of Utah Medical Center. And I don't know if you know, primary and the U are connected by a bridge. And so the baby's stabilized and sent over to primary. But often these babies are born with undiagnosed issues, and it's only after birth that they then are emergently transferred to this level 4 for consultation and ultimately surgery. So I've had the honor of working in the NICU for many, many years. When I meet a family for the first time, I'm very interested in just where they live and what brought them there. So many families travel from far away in Utah, Nevada, Idaho, Montana, and we've even Alaska. And it depends on the specialist they're going to see, why they're transferred to the level 4. I find that acknowledging where they live, where they're living now, how their work, family, and personal lives have been upended is part of the relationship we as developmental care therapists, we must do this. So I looked at the census at primary, I don't know, a couple of months ago. And then I look at the census at the level 2 and 3 hospitals. And the level 2 and 3 hospitals, mostly the descriptives of the baby are prematurity. Once in a while you get respiratory distress syndrome or trisomy 21. However, the level 4 list is extensive with diagnoses that are rare and daunting for any of us. So I've highlighted the ones I'm going to talk to, but this is just the first page of the diagnoses that were up that day. We had a tracheoesophageal fistula with esophageal atresia, tracheomalacia, congenital diaphragmatic hernia, omphalocele, gastroschisis, all the bowel things that can go on, your bowel obstruction and perforated anus, duodenal atresia, cholestasis, and then necrotizing enterocolitis, hypoxic ischemic encephalopathy, intraventricular hemorrhage, hydrocephalus, and perinatal stroke. Second page, hypoplastic aortic arch, all these interesting cardiac rhythm and rate issues, your SVT, prolonged QT, heart block, all which need remediation or the kid's not going to survive. But typically you get that sorted out and they're way to go. Congenital heart disease. Aspergillosis is a fungal infection. I had to look it up. That is typically in the very preterm infant lung, and it's a fungus, and it's very hard to get rid of. So that's life-threatening. We had respiratory distress syndrome, bronchopulmonary dysplasia, neuromuscular disorders, trisomy 18, genetic issues, congenital anomalies, and then a lot of kids with tracheostomy, ventilator dependent. The diagnoses list may or may not have long-term developmental sequelae. Many of the infants are born near or at term. They're transferred to the level 4 for surgical intervention. They heal, they learn to breathe, they eat and go home. However, some of the kiddos get the repair and they don't improve. They struggle to get off their ventilating support. They struggle with a variety of comorbidities like feeding intolerance, failure to eat by mouth, and long-term health issues. I think the longest kiddo I've seen get discharged home was 15 months in the hospital. And that's a long, long time for these little ones. So Rebecca and I were concerned about those babies sent home to rural USA with little or no support, no home health available, specialists hundreds of miles away, and rural hospitals with little or no knowledge about how to support children with fragile health care. So I want to look at the following diagnoses that delineate care at a level 4, their complex developmental needs and difficulty with local community support. Before I get into this, I encourage all of you who are serving these children to listen to the family about what's gone on, but go and do some research about just what this child and family have been through. So the first one is gastroschisis. And I know you get a 10-week blood test, ultrasound, and a 20-week ultrasound. And so a lot of these abnormalities are identified at the 20-week, and so the parent can prepare. But if you're born at a real outlying rural hospital, these are some of the daunting things that can face your delivery room staff. So gastroschisis, it's a rare anomaly. It occurs 1 in 2,500 births. And it occurs at 11 weeks of gestation. So it's a very early anomaly. So it's when the intestines fail to move back into the abdominal cavity. So the intestines move out and into the umbilical cord about 8 to 10 weeks. And that's to allow for the diaphragm and the lungs to develop. And then they get a signal to come popping back in. The problem with gastroschisis is there's no membranous coverage. So the intestines are exposed to amniotic fluid, which increases the inflammation to the intestines, including malrotation. And so here you have a little kiddo that's stabilized, seems to be pretty stable. She's not on a ventilator, just has a nasogastric tube and some monitoring, but they have really stabilized the defect. And they wrap it in sort of like a silica plastic, to keep the water in, and then gradually put the intestine back in. So there generally are no associated other congenital anomalies with gastroschisis, and the size of the anomaly dictates what happens. So I just saw a little guy who had just a little blip of his intestine sticking out, and all they did was poke it back in, and I think they just put tape over it. He was preterm, so he had other issues, and then they didn't even require a stitch. But others require, depending on the damage to the actual intestine, how inflamed and rotated it is, the reductions can take over weeks. So obviously these kiddos have feeding issues, digestive issues, can be long-term, and prolonged hospitalization. Some kids go home and some kids have a lot that keeps them still hospitalized. So omphalocele is another intestinal disorder, and it's a pretty gross pick, but all of that is in the umbilical cord. The occurs in the abdominal when the abdominal viscera herniate through the base of the umbilical cord during 6 to 10 weeks outside the abdominal wall, and they don't go back at 11 weeks. And along with omphalocele, it's our trisomies 13, 21, or 13, 18, 21. And Beckwith-Wiedemann also is associated with omphalocele. It occurs in 2 to 3 of 10,000 births, so it's pretty rare. And fortunately, the viscera is covered by a membrane, and they don't necessarily do surgical reduction. So I've seen a couple of these kiddos, and what they do is they put a shell that's a hard shell that keeps the moisture in, and they change the size of the shell as the defect is reduced. And so these kids have tremendous positioning issues. You can't put them on their belly. Putting them in the car seat is pretty interesting. And they can't, I've seen kiddos go home with this shell in place, and associated issues obviously add to the developmental challenges. And then here is a really tough one. It's a congenital diaphragmatic hernia, and I don't know if you can see that the diaphragm is only developed on the right side and not on the left side, and all the intestines are up in the chest cavity, pushing that left lung over, if it at all is developed. So during the 8th week of gestation, the diaphragm fails to fully develop and close off the connection between the lungs and the intestines. So at that 11th magical week, when the intestines are signaled to come back into the belly, instead of staying where they should be, they migrate up into the left lung space. It occurs in about 1 in 4,000 births, and most of it is left CDH. So you can see in the diagram where the left lung is really tiny, and all of these organs, the stomach, are pushed up and over past the diaphragm. So this is a pretty serious defect. It's usually seen on the 20-week scan, so babies can be delivered at the University of Utah and transported to primary. So the statistics show that if there's no respiratory distress in the first 24 hours, the survival rate is 100%. And if the infant requires mechanical intervention in the first few hours, the old statistics said that 50% of them survived. However, nowadays, to treat the pulmonary hypertension, to treat the obvious immature lungs and the inability to ventilate, they use nitric oxide. They use more sophisticated ventilation, and in some cases, they will put the lungs at rest and put the kiddo on ECMO. But recovery was, yes.
There's a question and it says, is the heart development affected by the congenital diaphragmatic hernia?
It's not necessarily the heart, it's the pulmonary system, or you get pulmonary hypertension because of the lack of lung development. So the circulatory system is affected. And my experience with it, I could take all of these single diagnoses and spend a whole lecture on them. But my experience is it's the impact to the lungs, it's the impact to the intestines, it's the prolonged ventilation these kids need. And so often recovery is long. Many of them have horrible feeding issues and often need a G-tube. Well, they need a G-tube. Some of them need to be on a ventilator with a trach for months, if not years. And the developmental outcome is pretty grim for these kids, just based on their medical needs. So this is a stricture in the esophagus. It has been attached. So I wanted to talk about tracheoesophageal fistula and esophageal atresia. So there is a stricture here, and the kiddo is supposed to have scopes to make sure that liquid can pass. And then once the esophagus is attached, then feedings are started very slowly, and they do lots of scopes. But I've had kiddos go home and they have this stricture, and liquids are tolerated. They can do bottle feeding, but once puree and solids are started, it may create significant feeding issues. So it occurs in the first 22 to 36 weeks of gestation. And did you know the trachea and the esophagus are attached in utero? And it's when the trachea fails to separate that these atresias and the various types of esophageal atresia occur. And the 20-week ultrasound definitely shows polyhydramnios, which is too much fluid, amniotic fluid, and no stomach bubble, which indicates that the kiddo's not swallowing. So a lot of parents are prepared. However, some aren't. And the baby's born, and you try and feed them, they vomit. They get an NG tube, they try and insert it, and it doesn't pass. So they do an X-ray, kiddo's then shipped to the level 4 for intervention. So these are all the types.
On. I said, just before you move on to other things, there's another question that says, do you know anything about long-term survival for CDH?
Oh, I'm on a CDH Facebook that one of my wonderful moms put me on, and the survivals can be grim. I mean, these kids have I mean, the pulmonary hypertension is significant and severe. And it depends on, well, so years and years and years ago, I remember a baby being opened up. There was no diaphragm, and the surgeon closed them and said, there's nothing we can do. I mean, basically, there's no lungs, and the baby is full. Her intestines are where her lungs should be. Um, but there's been more aggressive. So if there's a little bit of diaphragm, they do different kinds of patching. I mean, I'm not an expert in any of this. I just work with the kiddos and I listen to the parents' stories. And it's a hard diagnosis. It's a really hard diagnosis. And some kids just fly through it and go home. And other kids are impacted long term. So and I don't know the statistics on survival, but our surgical intervention, our level 4 NICUs are miraculous in what they can do now, especially with the kinds of ventilations that are employed. But it's still not a good diagnosis depending on how badly impacted the diaphragm is. So 86% of your atresias are here, and that one's interesting because it's still got a remnant attached to the trachea. But the long gap ones, which is here, they're the harder ones to repair. And it depends on whether also there are other genetic issues that go along with it. So G-tube may be needed to be placed if the kiddo has long-term feeding. Interesting story. I'm going to talk about this story. A little kiddo I saw for years had, better check my time. Oh, my timer, darn it, didn't start. You gotta let me know, Jenna, when to shut up. So she had to go in and get dilated every month because of her strictures. And one day she ended up in the hospital, and the mom said, well, here she doesn't eat anything, but they pulled a small Lego out of her esophagus that her brother had played with and she'd swallowed. So you tell me how she could swallow a Lego, but she wouldn't take any of the puree that we were offering her. So interesting. Okay, so this is sort of cardiac disease is the most common genetic congenital abnormality with 1 in 1,000 births, but it ranges from a murmur, to small VSD, small ASD, to larger disorders. And the kiddos that are the most impacted with cardiac have feeding and swallowing disorders. And this is a shout out to all of you that are working with kiddos that have had VSDs, who have had aortic arch issues. 50% of these kiddos have issues with aspiration and vocal fold dysfunction and subsequent feeding issues. So early referral for a feeding assessment, definitely getting a swallow study or an MBS is before discharge. But if you have these kiddos on your caseload, I would heavily suggest that these kids have a swallow study. Simple remediation is thickening. All you need to do is thicken those feedings, which helps the kiddo progress to full oral feedings and protects the airway and prevents long-term lung disease. So you play a good role in our early intervention program. And just recently, I've had 2 kiddos that had their cardiac repair sent home and were literally gurgling and dying every time they were given a bottle. And lo and behold, they were aspirating very nicely on everything that was given to them. So thickening got them over the hump. Okay, so these are the neuro things. Your HIE, your hypoxic ischemic encephalopathy, it's a brain injury. 1 to 2 out of 1,000 live births. Your interventricular hemorrhage, it usually occurs in babies less than 1,500 grams. It's where the brain bleeds into the ventricular spaces. Hydrocephalus, it may be congenital and related to other neurological issues or as a result of severe interventricular hemorrhage. And perinatal stroke is an interesting one because it occurs between 20 weeks or 28 days after birth. So it is a very interesting assault on the brain. So all of these neurological issues can be seen in a level 3 NICU. However, transfers to a higher level of care usually occur when surgical intervention is needed. If the kiddo needs a shunt to control hydrocephalus, if their neurological issue affects breathing, or a tracheostomy is needed, and finally, if they require a G-tube to support nutrition. Your perinatal stroke, as I said, is interesting. It can emergently affect the infant, depending how severe the stroke is, or it may go undetected until asymmetry is noticed. And I've evaluated kiddos where they're not using one side or the other, and they're like 4 months old, and it's like, we need an MRI pretty darn quickly, because you worry about tumors and or strokes. So again, all of these neuro diagnoses are variable in presentation and treatment. So issues affecting the colon, the anus, and the intestine are many and complex. Once emergent or planned surgeries are conducted, the infant often has an ileostomy or colostomy, which reroutes how the stool is collected. There's a wound and disruption in the abdominal wall. So feedings are slowly started back up, and it depends on that individual infant's response. It can be a long process. Feeding is often complicated by intolerance to the food being given, reflux, poor gut motility, too much stool, or not enough. And these infants may have lifelong issues with digestion and absorption, which affects development and well-being. However, if you're picking up some of these kiddos in the community, take into consideration they've had disruption in their abdominal wall. They've had surgery that has cut through their little abdomen. And so things like being efficient in prone and being able to push up in prone, stretch of the scar may be enough to keep them from doing that. Sitting, the scar tissue. So get involved with seeing the why because of their abdominal issues, and not, oh, they're just stubborn or whatever. And I know none of you say that. So it's basically supporting the family, supporting the baby, and saying what happened to them to make this such an issue. And then we have our little trach vent dependent G-tube kiddos. And there's a cute picture that I got off the internet. I hope nobody will report me. So for a variety of issues, babies require tracheostomy with ventilating support, and they invariably have a G-tube for feeding. In a city, I have seen one kiddo who ate totally by mouth, who just had a trach, and she had a trach for her vocal cords were closed, and so she couldn't breathe on her own without the trach opening everything up. But otherwise, most of these kiddos that I see have other things. So in a city center, care can be complex, but home health and multiple specialists are available. However, in our rural areas, services can be sporadic, access to specialists requires lengthy travel, and the challenges to development are broad, from communication. You can't talk if your airway is opened with a trach and a vent. Their fine motor, all that midline work that needs to be done with your fine motor is disrupted because you've got all this garbage right here. So they end up playing with their trach vent tubing and not really being interested in much else. So the challenges are great. The chronic health issues and the sheer volume of equipment that needs to accompany the infant often makes it impossible to access outpatient services. So we provide in early intervention is vital for some of these kiddos, especially if they don't have home health therapy services. So the story isn't over. I know that many of the littles that we see confound us. Some start out as babies with feeding issues, developmental issues, but as we work with a family, more and more issues present. A family sees more specialists who just don't know what's going on, and everybody's frustration rises. I have one little guy that I've been following for almost 3 years. He's not quite 3, even though I said he is. He started out with some cardiac issues, respiratory issues. He had failure to thrive, got a G-tube, but his issues kept evolving. It's like he's now had 8 surgeries, really, really intense, complicated surgeries. And he's now seeing a metabolic geneticist due to some pretty dangerous metabolic issues, hypoglycemia. He's got all these odd thing. So our issue, our support is what we do. We support these families and we try and find and support them in their journey of figuring out what's going on with their littles because they're confusing. So how do we manage these kiddos? So this is Rebecca's piece of it. So obviously there's long distances to specialized healthcare services. There's a lower percentage of health insurance coverage. And then there's parents' risk factors that don't necessarily, these exist in our large cities, but it's access to transportation that confounds the rural issues. So substance abuse, smoking, just having a driver's license, lack of higher education, and less prenatal care. And she specifically wanted to talk about the indigenous rural communities. There's loss of these kids to follow up. There's inconsistent community services and supports. There's distrust of a system of care. I think often they are targeted and not valued for their values. So they justifiably distrust what's going on in our so-called helpful communities. And then again, allocation of resources. So barriers are, I didn't even think about this, that there's low birth rates are higher. And I think that she meant that there was just less birth. So therefore there's less support systems. There's more preterm births and they're less likely to receive preventative medical care, including well baby checkups, vaccinations, dental and vision checkups. So the recommendations are to identify the barriers for the family and try to connect with resources. And this is where I don't know. I know about CHIP, but then she was saying for right track families or children aging out, connect with the Navigator program for Medicaid or other insurance options. There's a education to parents, including programs to cover the cost of vaccination, infancy program, etc. Identify the gaps, and look for opportunities to advocate for change. So she mentioned a pregnant mom with high blood pressure or a baby with a trach and a G-tube. If you notify your local ambulance services and collaborate with them in case of emergency, they're top on your list to come and help. And again, collaborate with partnering agencies for wraparound services. So this is where she mentioned increasing numbers of home births and ensuring that the family have access to that blood screen at 10 weeks and that 20-week ultrasound and hearing screens. So that's what she wanted for discussion. So there's my very bad credits, but I will say that most of my experience is anecdotal and on the job. So stop sharing.
But there is a question.
Uh-huh.
Can you see the question?
Let me look.
Back a little bit. So if I can find it, sorry, Mike keeps playing. Says, what is the role of ultrasonography in the?
Because it shows the intestines out. You know, you do a 20-weeker. So this anomaly happens at 11 weeks with omphalocele and with gastroschisis. And so if you do an ultrasound, you can look. So it's essentially, you're looking at the aorta, you're looking at the diaphragm, you're looking at so you're looking at all these systems. And I was literally there when somebody I won't mention who was pregnant with a child who I'm somewhat related to, and I was there for the 20-week ultrasound, and it's thorough. They look at all of the organs, and that's how those things are diagnosed. Is there anything else? No.
We do have a few minutes for questions. If anybody wants to come off mute or put them in the chat, Pat can take a few questions.
Audrey has a question.
Audrey.
Yes, thank you. I'm in Moab, and I don't know how much you know about this, Pat, because it sounds like Rebecca knew most of this, but like the things you went through on that one of those last slides, the right track program, the navigator program, the infancy program, I'm like, what are these? I have no idea, and I really would like to know.
Yeah, we need to get Rebecca to
So,
stand on them. And she has references on the credits. The last two references are hers from 2020. And I assume that due to being in a rural area, you have access to programs that help families. I'm just thinking of some of our indigenous, and I have provided services on reservations, on a very limited basis. But I don't know now what services are available. And so I'm sure you can email Rebecca and say, what are you talking about, Rebecca? Unless you guys know.
yeah, so the Right Track program in North Dakota, can you guys hear me?
Mhm.
The Right Track program in North Dakota is basically a free screening program for kids. So a lot of times when they are worried about development or something, they often go through Right Track first just to see how they do on that screening. And then obviously if they need, a full evaluation, then they'd go to early intervention. The Navigator program is a project that helps families and I guess just individuals around North Dakota get health insurance.
Mhm.
And then infancy, and this, I might be wrong about this, is just a program for, I think, vision screenings
Mm.
as
Shelby,
infants.
Infancy is a nationwide program that
Yeah.
vision providers can opt into in North Dakota. A lot have kind of adapted their own as well. They don't necessarily because I think how infancy works is there is a portion like you get grant money, but you also have to pay something into it as well. So a lot of vision providers over the years here have just adapted and do their own free vision screenings for kids under 1. It's also kind of their way to then gain a patient too over time to keep following those kids with their vision concerns.
Yes, that was much more eloquent than I would have put it.
Thank you. Audrey, there also is saying things like, oh, that's from you. So like Utah's Help Me Grow or our care coordinators through DHHS and or our NICU follow-up as well.
And so the Navigator program, is that a nationwide, or would that be our care coordinators, which I don't know much about and would love more information about?
I don't know a lot about navigators. I know that you said in Minot kind of runs that program, but that's something I can find out and send to you.
I know in a group I was in a past one, they were telling me about the Help Me Grow, and it sounds a lot like North Dakota's experienced parent program, where we have parents who have had children in early intervention before, and they've learned a lot about the system that they support and help families connect with other families who've had kids with similar diagnoses and things like that. So that's kind of what it sounded like that Help Me Grow was similar to.
I think Help Me Grow is actually more similar to how you described Right Track, because Help Me Grow does screenings and then they also send families like developmental activities and stuff. I don't know about connecting with other families though.
And then Crystal has put that the navigators in her area, and she's down in southern Utah, are housed at the Sliding Scale Clinic.
So Pat,
Mhm.
it's Nancy. It's funny that you talk about this because I just did an IFSP yesterday on a child with an omphalocele, and that's probably the least of his problems.
Yeah, yeah,
He's-
can you guys hear me?
Yeah,
Okay, yeah, it goes along with other genetic abnormalities. And
yeah,
you're right, because I've seen a couple of kiddos and they didn't have trisomy or they didn't have Beckwith-Wiedemann. They had just really like a missing hand or digit. I mean, they had a lot of just other anomalies. And oh, by the way, so it's almost like the signaling system that tells the guts to go back in is also affecting other organs as well. So
yeah,
it's interesting. It's an interesting anomaly.
yeah.
And
He's trach invented,
yeah,
and heart issues, and I mean, the list goes on and on and on. It's like I just kept reading more and more and more on this kid. But he's also got a paralyzed diaphragm,
Wow.
partially paralyzed diaphragm. So I figure that's why he's on the vent. But he is able to make some sounds around that trach.
Yeah.
He's only 10 months old and he was in the hospital for like 8 months.
Oh, poor little boo.
So
I
yeah.
mean, that diagnosis, the gastroschisis, isn't as daunting as omphalocele. And just the fact that they don't do surgery on it. Did he have a shell around his omphalocele? Yeah.
He's not wearing it now. And it looks like it almost like alligator skin over that middle.
Yeah.
And mom is not very, I'm not going to say she's not intelligent, but it's kind of like she just doesn't understand everything that's going on around her. And so she's going to need a lot of teaching, but it's almost like she did mention that they are going to do surgery. But he's also got a hernia that needs to be repaired. And he's only got an NG tube. They have not done a G tube with him yet.
I think they don't
So
do G-tube just because of the abdominal wall.
yeah, so it's, it's still a lot of things that are going on with him. I almost wish I could go to a doctor's appointment with her just to hear what the doctor says.
I mean, if
Oh.
you have intellectual issues, I mean, having multiple anomalies, I mean, that's daunting. I mean, I would be daunted, but that's daunting for a family. So the more support they can get, the better.
And Pat, that brings up a really interesting point because you had said for others to go ahead and do some research about that, like whatever they're dealing with. Do you have places that you recommend that we would go out and do research, or?
You can Google it, which
Okay.
Dr. Google is always available. And if you go into Google Scholar and just put the anomaly, then you'll get PubMed articles. But I think the biggest thing that I've learned is I have this neurology, or this it's a neonatal intensive care book. It's almost 18 years old, and it's just old knowledge. It's talking about kiddos with HIE and saying we're now experimenting with cooling, and it's like, hello, those kids are cooled. Those kids are cooled. So I think it's important to ask the family what's going on and then do your own research, just so that you don't. I find that if parents know that you're in partnership with them about what's going on with your kiddo, it's going to be a partnership until early intervention is over. So I think it's very, very important. That's what I'm saying, research. So you get your medical descriptives from the hospital. But I think it's also interesting to know other things. And especially if there's anomalies associated with the diagnoses, you're going to be watching, right? For those other things that might be going on that nobody's identified yet.
Okay. And then Katie just also put in there, she loves doing the research for NORD. And there is medical home portal also, if everybody on the call doesn't know about that place. And yeah, Shelby's saying, as parents really appreciate knowing when you've tried to learn more about the specific diagnosis that their child has. So other questions that people want to ask Pat around situations with NICU babies, or?
Not a question, but I just appreciate you kind of bringing up that point of getting that feeding evaluation or that swallowing evaluation with the cardiac issues, because I feel like it's something that's so overlooked.
I'm on mute. Yeah, so the cardiac team, the cardiac follow-up feeding clinic at primary, Courtney and Courtney and Casey are the OTs. No, speech therapists that do it. And they've done presentations to the cardiologists, they've done presentations to other groups that say, you guys can't, just because they're eating doesn't mean they're eating safely. And they're going to deteriorate as they get older. They're going to start saying, I don't want to eat. So we had a little guy, Ellie, had picked up this little kiddo, and I think he just had a VSD, but it was a pretty bad VSD. And he wasn't gaining weight. He was tiny, tiny, tiny. And he finally went back in, and Courtney did an MBS and said he's frankly aspirating on everything. I mean, and so it had gone under, nobody had referred to her. Like they hadn't said, oh, by the way, there's this kid over here. He had other issues, which I'm sure they say, oh, well, it's because of those other issues. But I think more and more aortic stenosis, I was reading something where the stenosis is, it can push on the anatomy and direct the fluid into the right lung because of where it is. I mean, we need to always be thinking out of the box. And I think we need to refer these kids, if they're struggling with feeding, to our speech and language pathologists, and then reach out to our medical community and say, do you know this kid, what's going on? So.
And that brings up the next question that Crystal has, and it says, how do you think we can best support these families as they come home with these difficult issues, especially when we're reaching out the first day or two that they are home?
Yeah, I always follow the parent lead. You know, what can I do? You know, what do you want me to do? Because managing a kid that's hooked up to continuous feedings through a G tube, hooked up to a ventilator, oh gosh, what else? They've got their SAT monitor. They've got all this stuff. I think being very cautious and being very respectful of that baby and family, asking a lot of questions, but do something. Like, do something. Like, show them a different way to hold them, show them, you know, do something, because they do appreciate, with the limited ability you have, to fly them around on a ball. I mean, I've put kids trach vented G tube on a ball, you know, just kneeling on my lap, nothing's being pushed on, and get the different perspective. Just do something that gives the parents some hope that their kiddo is going to develop. But again, so much respect and following the parents' lead.
I'm going to take this last question from Audrey, and then we'll move on to our case presentation.
I just wanted to say, in the rural areas especially, it seems like sometimes the best support we can give is to be there with them, and then do things like help them find care for their older children or their other children, or things like that are super, super practical that a good friend would do, but they haven't even had a chance to reach out to a good friend if they're trying to deal with a trach tube they know nothing about, you know, that kind of thing. So that's been where I've gotten the most gratitude, like, thank you for helping me with that, or going to a doctor's appointment with them or whatever to help take notes. Just being on their team, but not getting in the way. I really need to have my appointments on Fridays. Well, that doesn't help them much. Be as flexible as possible for their schedules and that kind of thing. Pretty straightforward.
Thank you. So we have our case presentation from Kate Murphy today, and we also are lucky because we have the family on our call. So I'm sharing my screen, and I will let Kate take it away.
So I'm Kate Murphy, and I am with the Minor Infant Development Program in North Dakota. I've been doing this for going on 8 years now. So the background on my case, and I have had this little peanut, oh, let me see, since she was 5 months old. So right now she's a 10-month little girl. And the family just back in July found out that she has this chromosome XP11-4P11-22 duplication. So like I said, she's been with me since she was 5 months old. We have had monthly occupational therapy consults since the initial IFSP, and same with physical therapy. They are doing physical therapy. They're hoping to get that switched to weekly. They're waiting on an occupational therapy referral. And then they did have one direct speech and language visit, but they were at the time unsure of how to move forward. So they were kind of holding off on that. So at her initial evaluation, she did have global delays. In July, they did a swab that they sent off and it showed that duplication. The geneticist in Fargo, which is about 4 hours away from where the family lives, says that this duplication shows up in females and then it can either be dominant or recessive. At birth, she was also diagnosed with an atrial defect and a PDA. So she had surgery at the end of July in Denver, Colorado at the Sanford Children's Hospital, and they will be going in about a month to have that checkup. But surgery went well, and they were able to come home shortly after that. So, okay, bear with me because I am not good with medical terms. So she had an ophthalmology appointment. Hold on 1 second. Colorado Children's Hospital is where she had surgery. So she had an appointment in Fargo on April 3rd and after she was born, and it was determined that she would benefit from eye muscle surgery. So she was supposed to have surgery on September 4th, but she went to urgent care and she had pneumonia-like symptoms, so the anesthesiologist canceled her appointment. And their soonest appointment in Fargo is December 16th. And when the family goes to Colorado, they are hoping that maybe something can be done there. I don't know if Brianne has any updates on that, but
sorry, I'm not meaning to cut you off.
nope, totally cut me off.
My apologies. No, so she wasn't able to get her eye surgery scheduled during that time that we go for the bronchoscopy, only because they're not accepting new patients. So we had to stick with the December eye surgery and then the bronchoscopy, but I will let you finish.
So that is where we are with her eyes. Okay, so primary area of concern is her aspirating. So they actually have another swallow study coming up on October 8th. So she's starting purees and they just want to make sure that everything is going good with those. Their other concern is meeting her developmental milestones in time, because this duplication, everything that they've read, all the kids that have this have significant delays. And then mom also wants to just monitor her brain, make sure it's not hypertonia, and if it's not, that there's not a possibility of a brain block. Shelby, yes, she was aspirating on, hold on, I have all my sticky notes, so bear with me. She was aspirating when they were in Colorado, and I
see now on here it says
there we go.
on
Yep,
thicker liquids,
I knew I put it in there. I just couldn't remember where in the slide it was, but yeah, so those are her current goals. She actually has her 6-month review coming up next week, so hopefully we can update those coming up. And then barriers, mom, at the time that I did this, and it's kind of been updated now, so if she gets a feeding tube at the time, they weren't sure if she was going to be able to attend daycare at the CDC, but it sounds like someone there has training in the feeding tube area, so she would be able to attend there. She aspirates on those thicker liquids, and specialty appointments, if anyone knows how rural North Dakota is, her specialty appointments are all over 2 hours away, some being 4. and Denver either being a plane ride or a 12-hour drive. So her primary pediatrician is here, and then obviously we have the emergency room. So when she was in Colorado, she had 2 different swallow studies completed, both of which showed she was partially aspirating it. I got to see the video, and that was super like amazing to me, just because I've never seen that before. So that was really neat to see. But they noticed that there was excess food coming out of her airway, causing her to aspirate. And then again there, in July, she had the second swallow study completed by the ENT, and she aspirated on the size 2, and they noticed she did better on the thinner liquids rather than the thicker liquids. So I updated this here on 10/28 because they had wanted, when I was completing this, wanted another swallow study, and then they were going to get one next week. So I gave them a switch to kind of help communicating and that motor planning process, just with like some sensory input, and we talked about how to work the switch and everything. And Brianne states that she has an irrational fear of how thin the water formula mixture is. Pre-made liquid formula seems to be thicker, but however, it is more expensive for the family. They saw a pediatric geneticist again on September 20th, and they say that the duplication of her gene kind of answers all of their questions, that there isn't anything more on the genetic side of things. Family is not from North Dakota. They are, both mom and dad are working full-time U.S. Air Force. They have a 4-year-old sister. They do have, their family is very involved with them, but obviously they are not local. And there is a possible switch for family members for their job in the near future, just to help with their child's medical needs. So I've been talking with mom, and we were talking about just some questions or some answers she would like to things about how to get more aware of childcare services to assist families with children with higher needs in a rural area. So like those respite things or anything like that. And then the child is still struggling with her head control, but starting to eat purees. So wanting just a proper seat to feed her in, which we kind of found one, I think when we were at our last physical therapy consult, but that's kind of where we're at. I'm not sure if mom thought anything more of any other questions she might have, but.
I haven't. I really don't know, like what more questions to ask in the sense of her circumstances, I guess, only because a lot of it is just kind of like wait and see how she develops, and then with the swallow study that'll answer more questions for us on as far as what she can eat and what she can't, or if we need to go ahead and make the decision to just do a G-tube, and then obviously not wanting to disrupt the quality of life for my child just because she does enjoy eating. And if we can partially eat by mouth and then also have a G-tube for things that she may aspirate on, I think that swallow study will answer a lot of questions for us in that aspect. And then when we have a bronchoscopy done on November 1st, if it does show like there's pneumonia present or something like that, it'll probably answer a lot more questions too, as far as like if she's still aspirating as much or if she isn't, and if they're needing to do any type of intervention as far as like surgical or something like that. I'm really unsure of how that process goes with them. But I think that's all I got right now.
She definitely does love to eat. If the mom is not feeding her fast enough, she lets you know, and it's very, yep, she wants her food and she wants it right then and there.
Shelby has one question.
Yeah, can you kind of talk about the one visit with the speech therapist? Like what was that? Was that for language? Was that for swallowing? What was it for? Do you remember?
It was more like an introductory type. Do you wanna talk about it, or do you want me to talk about it?
You can talk about it. I was just trying to find my notes from when it was.
Okay. It was just more so like an introductory meeting with her and just kind of seeing like what level our child was at. But as far as anything that we've done, she just kind of like see how she responded to things that were like around her mouth, in her mouth. But we didn't really plan a follow-up because we're just not necessarily sure what we need to do in that aspect. Because at the time, she wasn't taking purees as often as she is now. Now we do at least 3 purees a day. And at the time we weren't doing any. So we didn't really know how to proceed with that
Right.
with that service.
Okay. No, yeah, I was just curious what I guess the reasoning behind it, and if they were, because I would think they could work on some of that aspiration with you, but then again,
When we seen
there's not a lot in Minot for that either.
Yeah, when we had seen the speech therapist when we were in Colorado, they talked to us initially when we had seen the speech therapist here in Minot. They wanted us to switch her pacifier to the Philips Avent, the green one, because she had been using a MAM pacifier. And I only use the MAM just because I'm familiar with it from my previous child. And so we did switch to the Philips Avent, or a more rounded tip pacifier. However, my child didn't take it well. She just preferred the other one. And so I felt like it was just like we were in a position where we needed to just compromise. And we were using a Philips Avent bottle at the time when we were seeing the speech therapist in Colorado. And I noticed that she had been seemingly like struggling more. She was on a size 1. And she was seemingly struggling to feed on that bottle. So I was like, hey, can we do a swallow study to see if we need to up the size? Because prior to finding out that she aspirates, she was on a size 3, because she wanted to drink so fast. And then we realized, okay, she is aspirating, so we need to change the nipple size. And we did that. But with her growing over the last few months, I was like, okay, well, can we go up in a size? Can she take more? And then so we tried that during the swallow study in Colorado, and she was aspirating on a size 2. And so they decided to switch bottles to the MAM bottle since she already takes that pacifier so well. And when we switched the bottle, she did well on the thinner liquids, but I still wanted to do another study following up from that, just because I didn't want it to be like a one-off thing before we went home and didn't have, those resources that they provide there. And so they did an upper GI and a swallow study. On her upper GI, all the contents went to where they were supposed to go in the stomach. And then when they did the swallow study, they ran a bunch of different liquid size or thickeners, and she did better on the thinner fluids. However, she does like to hold her head back. I think it's almost like a protection mechanism for her airway. But the speech therapist said that she thinks that with how she feeds, that there's like no way around her not aspirating even with a thicker fluid. So at some point it is possible that she would need a feeding tube. And so that's why I wanted to do a follow-up and see, like, now that she's been eating purees and she's been utilizing those muscles for her mouth, is the aspiration still as prevalent as it has been before? If that makes sense. And then
No, that does.
Go ahead.
No, that does make sense.
Oh yeah. And then I know with like the hypotonia, the hypotonia and the laryngomalacia that she has, it does make it more difficult for her to strengthen those muscles so that she can swallow properly and keep things out of her airway.
Okay, so we are going to go into our breakout groups, and each breakout group is going to answer those 2 questions. So how to get more aware of child services to assist families with children with high needs in rural areas. And then the child is still struggling with her head control, but starting to eat purees. So what kind of, she's wanting a proper seat to feed her in. So breakout groups are going to ask those questions. We will rotate Brianna and Kate in and out of breakout groups. So when you see me come on, if they're in your breakout group, we're removing them. So Shayna, go ahead and open up those breakout groups and we will put you all in there.